Greetings and salutations, and thank you for joining us on Your World on this first Monday of May. Happy new month, and we wish you good tidings even as you plan and go into the new month. Now, Kenya has been hailed as one of the countries in the continent that has made tremendous strides to end the HIV and AIDS epidemic, but unfortunately, this season we are in has put these strides at risk. And I'm talking about the interruptions of some HIV-related services around the country due to the COVID-19 pandemic, and most importantly, the looming shortage of life-saving medication for those living with HIV. So, what lessons can be drawn from this season and ensure we safeguard the right to health for the over 1.5 million Kenyans living with HIV? We answer this and many other questions right after this highlights.
It's not something you can generalize and say patients are missing.
Today, as I mentioned, we talk about HIV treatment and the welfare of HIV patients.
Tunaomba serikali vile vile iweze kutafuta suluhisho.
Religious leaders asked the government to reassure HIV/AIDS patients of a constant supply of ARVs. And sub-Saharan Africans determined to reach Europe illegally from the Tunisian coast.
We're already sort of working with hospital systems in places like Africa.
Elsewhere, British startup Vati developed virtual reality technology to enable trainee medics safely learn and train their skills. Thank you for staying with us and, of course, joining us this morning on Your World. As I mentioned today, we take a look at the welfare of those living with HIV in this country. And that's why our question of the day to you is, what needs to be done to ensure uninterrupted provision of life-saving drugs for those living with HIV and AIDS? What needs to be done to ensure uninterrupted provision of life-saving drugs for those living with HIV and AIDS? Well, talk to us. That hashtag is a new normal. And remember, as always, we welcome you to give us a call using those numbers at the bottom of your screen. Now, before we get to that crucial conversation, let's take a look at the impact of COVID-19 around the world. And this morning, those numbers stand at 153,497,250 confirmed cases. Out of that number, 131,509,526 have recovered. And unfortunately, 3,216,367 have succumbed to COVID-19. So how does it look like in the country? Well, as per yesterday's briefing by the Ministry of Health, 160,422 confirmed cases in the country this far, and out of that number, 108,861 Kenyans have recovered from it. And unfortunately, we have lost 2,763 Kenyans to COVID-19. Now, do remember, even if we are being vaccinated, do not let your guard down. Wear your mask, practice physical distancing, and of course, wash your hands regularly with soap and water. And if you cannot get that, use your alcohol-based sanitizer. So some of the stories making headlines this Monday, and New Delhi residents receive coronavirus jabs as India opens up its faltering vaccination drive to all adults after reporting more than 400,000 cases in 24 hours. Indian authorities lowered their guard in the early part of the year after infections fell, lifting restrictions on most activity and allowing mass religious and political gatherings to take place.
I'm here with two of my other friends. I informed as many as I could, but then the slots were limited and only a few of them could get slots to come here or the other sites that are open for today. I really hope everyone gets this done as soon as possible and does not differentiate between which vaccine is.
My half of my family is right now positive. So now everybody wants us to get vaccinated. It won't like completely protect us, but it will ensure that even if we get infected, we'll recover fast. So that's a necessity now to get vaccinated.
Well, elsewhere, sub-Saharan Africans are determined to reach Europe illegally from the Tunisian coast, which has seen a peak in departures in recent months. The number risking the dangerous sea crossing from Tunisia is rising. For the first time, the majority on the boats are not Tunisians. Last year, more than 12,000 migrants coming from Tunisia landed in Italy, the highest number seen in recent times. One of the illegal immigrants says making decisions that hurt our families, that risk putting our families in mourning day and night, is so difficult. In other people's eyes, it's frowned upon to cross the Mediterranean, but we feel safe today to take the risk of crossing the Mediterranean to go to the other side, where we will be better seen, where we will be better treated in Europe, in Italy, in France, and everywhere else. Tunisia is too difficult. Now, when copper mining was booming in the Democratic Republic of Congo, a vibrant and distinctive culture of music and dancing sprouted among miners who worked for state-owned giant Geka mines. The farm faded, and with it, Jekoke music. And today, a handful of farmers keep the style alive, hoping it will rise again as Geka mines tries to get to its feet.
Marcel Tsipanda is a custodian of a forgotten music link to the flow and ebb of the DRC's largest mining company. In the mid-1900s, the Geka mine firm was the lifeblood of the Democratic Republic of Congo's mining capital, Lubumbashi, the center of work, health, education, and leisure. Tsipanda, 74 today, worked as a secretary on the mine. On weekends, he was guitarist for young groups paid by its social club to sing and dance for mining communities. And out of this microcosm came a new music style, known as Jekoke.
They bought us instruments, they provided us with instruments, and we would perform on a Saturday, for example. They'd say, there's a town that needs a group to play. They'd send us there, we get there, set up our instruments and play music until the early morning. We came back and the next day we go to work.
Jekoke's sound was inspired by musicians in neighboring Zambia, which was then the British protectorate of northern Rhodesia. That golden age of copper mining coincided with the heyday for workers like Marcel, but it was not to last.
There came a time in Jekamine, I don't know what got into them. The Jekoke was abandoned and neglected. It's like a forgotten treasure.
In 2003, the World Bank funded a redundancy program to cut a third of the company's 36,000 workers. As Geka Mine's fortunes faded, so did the performances.
At the moment, we can't afford to buy instruments, for example. If there is someone who could buy us a complete set of instruments, I could form a large orchestra.
Geka Mine now banks on cobalt, a mineral in abundance here and key in batteries for electronic devices. Will it pay off for Jekoke? For now, Tsipanda teaches the next generation and keeps his suit ready, just in case.
To South Africa now, and the country has tens of thousands of illegal miners, and in a country with an unemployment rate of more than 30%, it's just another way to make a living. These miners share abandoned shafts that are no longer exploitable for mining companies. And in Emelo, in the eastern regions of the country, we meet Bonging Kosi. This 31-year-old has been mining illegally for over 10 years now, and he does this to support his family at the cost of his health and safety.
I'm doing him. It means like we are trying to take out the coal. At least we can call us maybe a small scale mining. Yes, it's not good, but for us, ouch. We're sorry for the next generation because we're suffering now. I think they're going to suffer as well. You just collapse. The power goes off. Your body becomes so weak. Then you collapse. Then if no one gets you out of here, hey, that means you're gone. Interest to me.
Now, Tanzanian President Samia Suluhu Hassan is expected in the country on Tuesday, the 4th of May, for a 2-day state visit. President Uhuru Kenyatta is expected to receive his Tanzania counterpart in her first visit to Kenya after ascending to power following the death of her predecessor, John Pombe Magufuli. Leila Mohammed with our report.
Tanzanian head of state President Samia Suluhu Hassan has hit the ground running in a bid to what many diplomacy experts say is re-engaging with the region to bolster ties and relations. This week, she is expected in Kenya to engage with her host, President Uhuru Kenyatta.
She understands East Africa very well. And I think we are going to see more of an outgoing kind of a leader.
While bilateral ties will be part of the agenda, at the back of the minds of both heads of state will be trade differences that have played out on the common border points, including the latest spat about maize imports from Tanzania and Uganda, which Kenya claimed were unsafe for consumption. The issue has since been dealt with, as the Kenyan authorities say that their Tanzanian counterparts need to do more to enhance traceability of the grain. Kenya and Tanzania had cold relations during the Magufuli era, with many along the border experiencing firsthand the tug of war. Kenya is still looking to retain its position as the largest economy in the region, and while neighbors like Uganda and Tanzania have explored trade ties in transport, oil and energy sectors, Kenya hopes to reconnect with all relations and build new alliances. At the end of April, Tanzania had surpassed South Africa as Kenya's top remittance source, as dollar inflows from African countries into Kenya had dropped by 65% in the first 3 months of this year.
I see her, cultivating a culture of openness, which is something that has been missing in the last 6 years of the President Magufuli's administration.
Other than economic ties, Kenya shares a rich socio-cultural history with its southern neighbor, among many more issues, which many will be hoping will come out of the 2-day trip that has been announced Sunday morning by the State House, Nairobi. Leila Mohammed, NTV.
Now to a story that puts us into focus on the conversation of the day and the standoff in the distribution of ARVs may worsen as the Ministry of Health says they do not intend to continue relating with private U.S. company Chemonics International.
There are certain measures that we are going to take to comfort them as far as their distribution system, the acquisition and procurement is concerned. We have expressed to them that we have no wish to continue in the long term to deal with Chemonics. We have agreed to clear whatever is that they brought in at the moment in the country on the understanding that we don't have a long-term relationship with those people. And our position has been made very clear, not just by myself, but indeed by the head of state.
Okay, so we focus on the welfare of those living with HIV and AIDS in this country. And of course, top on that list is the ARV saga that we have been seeing. But then again, we need to also understand how things are looking like on the ground. But then again, there is a question that has been asked over and over again now that the government actually flagged off some ARVs to 31 counties and the rest of the 16 were catered for from Kisumu. Was there really a shortage in this country? Well, let's take a look.
We have our electronic system, which is called the Logistic Management Information Systems. And this is what hooks us up with the clients on the ground. They assess what they need and they log on into a system based on their needs and they order what they want.
The Kenya Medical Supplies Authority KEMSA officials say that trucks carrying HIV drugs leave their go-downs each month. And according to their records, each center is expected to have a supply of the life-saving drug for 3 months to keep the 1.4 million Kenyans living with HIV healthy. Homa Bay County is expected to get the lion's share out of the latest consignment headed to 31 counties, an issue that KEMSA now says each and every county has to key in the specific number of drugs it expects each and every month. Persons living with HIV in various parts of the country have complained of depleted stocks.
Those probably are specific which we need to go into because it depends on how you report. So it's not something you can generalize and say patients are missing. It's facility specific.
KEMSA has announced that the fresh stock that was brought into the country by USAID will arrive at their stores soon. They are, however, not able to explain the bone of contention between Kenya and the US government and whether the 90 million shillings tax KRA needed paid out before clearing the consignment could be released. USAID is reported to have sought a private distributor of the drugs and break away from KEMSA, which handles all medical supplies in the country.
We don't have that authority to speak on behalf of the USA nor MOH, but what we can assure you is that that standoff, as far as we are concerned, has been resolved and we should be receiving the commodities anytime.
According to a letter dated April 20th by the Chargé d'Affaires ad interim Eric Needler from the U.S. Embassy in Nairobi, the U.S. government has been in consultation with the Kenya government and other international donors to get medical supplies to Kenyans who need them. The U.S. government states that they will continue to engage Kenya until they find a way forward, and much needed commodities reach Kenyans who rely on them to maintain their health and livelihoods. Kenya officials have acknowledged a shortage of the same drug for children and says that this will be available soon.
The information I have is that it's being airlifted and probably should be having it within a week.
While 3 trucks were dispatched, 28 others had already left to various destinations across the country. Leila Mohammed, NTV.
And we are here to actually shed light on the welfare of those living with HIV in this country. And to help us along with this conversation in studio with me, Dr. Catherine Ngugi, who is the head National AIDS and STIs Control Program, NASCOP, at the Ministry of Health. We're also joined in there, the studio, by Nelson Otuoma, who is the CEO of the Network of People Living with HIV in Kenya, NEFIC. Also joining us virtually is Alan Maleche, who is the Executive Director at CareLin. Also joining us is Penina Mwangi, who is the Executive Director, Bar Hostess Empowerment and Support Program, BHESP. And of course, we have Patricia Aseroching, who is living with HIV, and she is a very vocal HIV activist. Thank you all for being part of this conversation. And I think we'll just go straight on and actually address the elephant in the room. Dr. Ngugi, what is the situation on the ground?
Good morning.
Good morning.
Yes, thank you very much. The situation is on the ground is that we have antiretrovirus. Unfortunately, we do not have the 3 months You know, before, for clients who are stable, we used to issue them with 3 months of dispensing. But unfortunately, because of the stocks that we have currently, we are unable to issue them 1 month. So no client right now is missing any medication because of even the situation that we have in the country. However, for one specific drug called Caretra that is taken by the pediatrics, we have a shortage, and the issue is because we have one manufacturer in the whole world whom we already paid to help us with to supply us with the drug in 2019. And as we talk right now, the drug is being airlifted. He mentioned to us that he had a shortage of the APIs, that's active pharmaceutical ingredients, that makes that drug. However, the children, what we have done is we have put them on other regimens to ensure that they can continue taking their medication, even as this one is coming. However, there's a very good light on the tunnel, because to replace that Caretra, we have another drug that has come into the country, not in the country, in the world, called pediatric DTG, dolutegravir. In Kenya, we were among the 4 countries in the whole world to ensure we put in orders, and we are putting orders of 25,000 doses for our children. So even those children who, because of the shortage we're having on this one, in the near future, we will not have such scenarios at all.
Okay,
yes,
just to clarify, for those who don't understand how the drugs work and which one is which, the one that is missing for the children, how does it help the children? Is it the children living with HIV or born of mothers with HIV?
The one that are living with HIV, yes.
Okay.
Yes.
And this is a shortage across the country?
Not even across the world, yes, because we have only one manufacturer. So, you know, HIV mostly, predominantly is within sub-Saharan Africa. So it's a whole sub-Saharan Africa that are missing this drug. And you see, as you make orders, knowing it's only one supplier, so then you are prone to, having, all of you scrambling for the same drug. And then when Corona came in last year, for the last year since March, we have had, he stated there was a very shortage of the active pharmaceutical ingredient, which was being used to make other drugs of COVID-19. Yeah, but now we've been able, because we already signed the contract with the person in 2019, so then that he's able now to give us the drugs. There's around several doses, thousands are coming in the country. And so we expect it within the next 10 days to have it in the country. But within from August this year, we'll be transitioning our children to optimized regimen of pediatric DTG. Yes.
Okay, now Nelson, you represent those living with this condition in this country. What are they saying, especially now that you have a perspective of the country?
Thank you for having me here again. As you can remember, we were here sometimes last year, and we were also with Dr. Catherine Ngugi, who has just spoken. And as you remember, I really congratulated the Ministry of Health, NASCOP, and Catherine during that time, because in the midst of COVID, they were able to maintain 1.2 million people with HIV on treatment, which is not an easy thing during the time people were avoiding hospitals and there was a lot of anxiety. And that happened because Catherine and the team very quickly in March decided that now they are going to do differentiated service delivery, as she has explained. So those who were stable, those who were virtually suppressed, were being given medication for 3, 4, sometimes even some people were being given for 6 months. And that is how we were able to navigate 2020 with that anxiety, and all these people stayed through the course of treatment. I think the challenge we have started partly part of last year, but it became apparent to consumers this year because people went to the hospital expecting to get their refill and dosages. And instead of being given the 3, 4, or 6 months they were expecting, we were given 1 month. And I personally reached out to Catherine and asked, what really is happening here? And I should also say that for some, in as much as NASCOP says give for 1 month, they were being given for 2 weeks. And right now, some even being given for 1 week. So it is true, adults have not missed medication, but the inconvenience of frequenting and crowding health facilities so that you pick your drug, and the anxiety of not knowing what you expect next. In some counties, they're being told, okay, what the stocks we have are now through, from next month we don't have. And I think that is what has caused a lot of anxiety. As for children, the pediatrics, whether prophylaxis to prevent HIV or the treatment, I think it is true, as Catherine has explained. I think our concern is this airlifting of pediatric medicines has been happening for the last 3 months. They started airlifting in February, they were still airlifting in March, and they were airlifting now, now we are in May. But the point I want to explain, if you may allow me, this inconvenience that is coming to persons living with HIV is that if you are prepared that you are going to get your medication for this period of time, and then you present yourself in a facility and you are being told, no, what we have for you is you have to share, so we will give you for 1 week or 2 weeks, I think it is something that is confusing. We could only wish that if we are in that situation where it is so bad that we cannot take care of these people, it should have been explained before. We should have taken time in February or in March to explain, even through NEFAC, and say, now inform the NEFAC membership that if they present in a facility, they will not get what they expect. So that has been part of the noise. And, but later, if you give me time, I'll try to demonstrate, because I have some of the medication here.
Okay.
I'll demonstrate with the real challenge that people are going through.
And definitely we'll get to that. Thank you for giving us that perspective. Now, let me hear from Penina. You represent the key populations, and they've also been hard hit by this looming shortage of ARVs. What's the situation from where you sit?
Thank you. The situation is very bad, and the key population are really worried. First, they deal with criminalization. And the reason why the government has always reached to us in order to close the tap of HIV, they have identified certain people as very vulnerable. Young women, the sexual minorities who are the gay and lesbian, and of course also the sex workers. These are people who are really clutching on their last straw. And we have always worried about things like side effects. We have worried about nutrition, because, of course, many of the people will live on less than $1 a day. So now we're worrying about drugs. We hear it's about tax. We hear it's about people's egos competing. We hear the drugs are in the country, but the inconsistency of getting the drugs. First, the people were getting the drugs after 3 months. Then 1 month, now here it's 2 weeks. And we worry, next week will it be possible? And for some people, even to go to where the drugs are, it's a lot of trouble. They don't have the fare. They have to decide whether to buy food or to take that border to go to the clinic and get drugs. But now we're even worried you go there and not get them. We fear we will go there and not get them, because now we started getting them after 2 weeks. So in our groups, the people, the sexual minorities, the young women are just talking about what happens next. Then they hear that maybe you'll have to bribe to get a drug. Maybe you have to. There's so much talk going on. We just need someone to take a go, even our president, to come and reassure us that they're doing everything, that they will not take the lives of Kenyans, the lives of vulnerable people for granted over anything at all. It's really a dire situation.
Okay, so a lot of uncertainty and reassurance is needed from the government. Let me hear from Patricia. Patricia, you are a HIV activist living yourself with HIV. What have you experienced during this season? Patricia, what have you experienced in this season?
Thank you so much, Gladys. This season has been a bit tough for us, especially as women living with HIV. Just to pick up from where Penina left, our members who are sex workers have found it very rough. You know that the sex workers move with the clientele. So if there's a business in Elgeyo Marakwet, that is where they head. If there's business in Narok, that is where they go. If it's business in the coast, that's where they go. So when you're being given antiretrovirals for 2 weeks, then that is something that is it's making women desperate, because as much as they are doing their business of sex work, they want to be able to suppress the virus, to keep their immunity competent, and to make sure that even as they go around their work, they're able to protect themselves and protect the ones they love. But when you are given medication for 2 weeks, and then you're supposed to go back to the said facility for another dose, and with the kind of work they're doing, the possibility is not high. And the issue of transport, you know that they've been locked down. You're told to go back after 2 weeks. Maybe you've been locked down out of Nairobi, and you are you are picking your medication in Nairobi. Then the process of even getting papers to come back to Nairobi, the transport cost itself, then people now are failing to take their medication. We know what the consequences are. That if you don't take your medication consistently, then you're going to have a high viral load. And then maybe the possibility of failing treatment is high. So if we are having trouble having medication for first line, then what about the second line itself? We are scared that the government might not be able to maintain us on treatment, but this is a right. And the government has the process to make sure that we have the medication in country. Our understanding, as Nelson has said, that we have a buffer for 6 months in the country. And now, as we speak, we are being told that what we have currently, from what we saw being flagged off, is maybe medicine for 2 months. And that way, in different counties, we are getting different reports. People in Nairobi, some people in Nairobi are getting for 1 month. In other counties, people are still getting for 2 weeks because people are not sure. So when we say that there's no shortage in the country, that's a big lie. We just need to be straightforward, say this is the amount of medication we have in the country, this is how we are proceeding to make sure that people are getting them, so that we can align ourselves and our minds about that. But saying that we don't have medicine, that we have enough medicine in the country, that's not true.
Okay, now the right to health has been questioned here, especially for those that living with HIV. And Alan, this is something that you actually advocate for. What do you see from where you sit?
Thank you, Gladys, for having me on the show. And from where I sit, having worked closely with persons living with HIV and also having worked with the Ministry of Health, they have done an incredible job in terms of trying to ensure persons living with HIV have access to ARVs, whether it's through government funding, whether it's through donor funding. And between the initial period of the lockdown, there was indeed reassurance for at least 3 months that people had access to medicine. But I think from where we sit, the concerns we have received from communities of people living with HIV, the sex workers, drug users, is that there is not clear information coming through them to know exactly how much medicine is available in the facilities, how long will they be able to get their medicines, and why can they not get them for 3 months. And so the positions raised by Penina, Nelson, and Patricia are actually correct and warrant the fact that we need proactive communication from both the national and county governments to be able to tell us, look, this is where we are with the stocks of the drugs, this is where we are with procurement, and this is how we need to manage things. Because the right to health, where you have ensured that people constantly get their ARVs without any panic, without any hesitation, a disruption in that is definitely and would be deemed as a violation, because you're then causing them undue stress, you're causing them undue anxiety, and you're causing them undue tension. So my position and the thoughts we've had with colleagues is that there needs to be more communication and honesty and transparency. Even if things are not going well, it's good to come to the table and say, this is the situation, let us try to find a solution together. But that is not what we have seen in the past few months. Over to you, Gladys.
All right. So this morning, at least Dr. Ngugi is here to, first, as you've heard, there needs to be reassurance. And also somebody who can be very clear on as far as where we are at in as far as the ARVs are concerned, and how each and every person living with HIV can be catered for. What's your position?
Thank you, Gladys, and thank you to Alan, to Penina, to Patricia, and Nelson, whom work very closely. I think I want to answer several areas that they need clarification, and as well as the reassurance. But I think the first question I want to answer is, how did we get here?
Yes.
And then I'll take you to of how we do plan in terms of getting the drugs into the country. So Either 1 year before, we do something called forecasting and quantification of the drugs. We know we have around 1.5 million clients living with HIV. And then we have identified 1.2 who are on treatment. So then we will sit down, that is adults and children. So 1 year, like around in the month of February last year, we sit down and plan and you see these are the drugs that we need to buy for the country for the next, now we're planning now for 2021, okay? So, and in that table, there is a Ministry of Health, there is KEMSA, there is county government, there is the donors I mean Global Fund, USAID is US government through USAID sits at the table as well. And then government as well is there. And we plan, okay, and I'll give an analogy. Like let's say we say that you're going to buy 1 million packs of certain drug. Let's say like now it's TLD. And so Global Fund will say, okay, we'll buy for you 300,000. And then USAID says, oh, we'll buy for you 500,000. Then you have government says, okay, we'll take the rest. So there's commitment now by Global Fund, by US government, and by government of Kenya of what is going to procure. So everyone now is set at the table, and we go to, remember as well as the year of budgeting of government is totally different from the US government. Their year starts from 1st of October to 30th of September. Ours is July to June. So that we have sat on the table and agreed that is in February. So then we plan now on something we hold every month, meetings called procurement planning meetings and commodity security meetings. We hold them every month that are convened by Minister of Health through NASCOP. So, and in this meeting, we have all partners sitting at the table. And so that is in February now, we have committed all of us. And so now we agree who is going to bring when, because we do not want the 1 million packs coming at once to the country. And remember, over the years, Global Fund USAID has been using KEMSA. We have a contract, we call it MCP, Medicines Commodities Program, that is signed between the US government and Kenya to ensure that we procure, warehouse, and distribute the drugs using KEMSA. So then what happens now is we agree, Global Fund, when are we going to initiate its procurement? US government when and government when. So we knew by the agreement we had in around February, March 2020, that US government over the years, it's not even this year alone, all over the years for the last decade, by 1st of October, we'll have their drugs coming into the country. So when it came to October 2020, when we engaged them through commodity security meeting and procurement planning meeting, they told us they're coming. We said, okay, fine, because there was no alarm, there was no communication. And then nothing came in October, nothing came in November, nothing came in December. So I reached out as the head of NASCOP to US government asking, when are we going to receive the commitment that you give to the country? And when I did that, we got an email and as well as a letter committing to the government that we will have drugs coming into the country by January. Gladys, nothing came in January. Nothing came in February. And that time, no communication. That's the time now we escalated the matter to our bosses, the Ministry of Health leadership, to our cabinet secretary and to our principal secretary to take up the matter. And that's why you see now the engagement is at that level. So how we got here is because of it interrupted the supply chain and the commitment that they had made. Because if they had committed, if they communicated to us earlier that we have a problem, 1, 2, 3, 4, 5, then the government would have been able to put in money and be able to procure the drugs for our people. Let me give you an example. In 2019, we have the drug cotrimoxazole that, thank you very much to the US government, that it used to buy for us all over the years. And honestly, for example, in achieving the epidemic that we have had, honestly, we would not have done it without the US government. And we are really grateful for so far they have brought us, and the Global Fund as well. So in October 2019, I was communicated via in a meeting that there's no more cotrimoxazole. There was no formal communication, nothing. I had to go and discuss definitely with the acting DG and the principal secretary and the cabinet secretary, and we are grateful that the government was able to put in money. But remember, you're talking of 1.2 billion Kenya shillings. So, and remember that is not small money and remember that our budget year had already started. And so we were able to plan in, and you remember October 2019 up to July last year, we had a lot of gaps of cotrimoxazole and so many anxiety like what we are seeing right now. So the question and the issue we are in and the discussions we are in is the commitment was not honored. It had been promised earlier, but the commitment from Global Fund, commitment from the government of bringing the drugs, and that's what we have. I know this question has been asked about taxes. According to the rules in the country, the legal framework, that if you do not bring the donations that you're bringing through the agreed signed contract between, for example, the National Treasury and the donor, and now, for example, within the Ministry of Health, then you attract taxes. For example, we have been donated for like pediatric, dolutegravir 50 milligrams through another channel, and we have to pay almost 500,000 Kenya shillings tax because we did not use the channel that is normally used. So why the taxes it attracted? It's because the contract that they had with KEMSA, they did not use KEMSA to procure in the warehouse. That's why it attracted the taxes.
Now, let me stop you at that point.
Yes.
Are we referencing to the 1.1 billion worth of HIV and TB drugs that was stuck at the port of Mombasa earlier in the year?
Yes.
Okay.
Yes.
And you said that no drugs had come in January and February, yet this amounts were stuck in the port. So which consignment are we talking about?
Okay, let me clear here, yeah? I've said that there is usually a contract that was ending December 24th, 2020. It was a 5-year contract between U.S. government and government of Kenya through KEMSA. Okay? So now, what happens is, if now you use KEMSA to bring in, you don't attract taxes because already the Treasury is informed and there's something called master list of commodities that have been allowed. Unfortunately, the US government brought the drugs to the country and did not use KEMSA. You understand? That's why it attracted the taxes.
And why did they not use KEMSA?
Unfortunately, that one I cannot be able to answer because it has not been clearly mentioned to us why they did not use KEMSA. And I do not want to speculate that one. I'll leave it to my bosses to answer that question.
All right. Yes. Okay, now let me throw this to Alan Maleche. We know that there has been a word that there are billions worth of ARVs stuck at the port, even as we speak. From where you sit, what have you heard and what is the stalemate?
Thank you, Gladys. And I think the stalemate was clear. The delegation by the US government that did a virtual tour was very clear and said the elephant in the room for not using KEMSA was corruption. And that was a fact stated by a high-level representative of the US government. And I think the issue we need to be concerned here is that KEMSA has worked before. And if it's not working now, what alternatives are in place to be able, one, to make it work, or to be able to get the medicines to people living with HIV? Because the concern Nelson has, the concern Patricia has, the concern Penina's constituency has is, how do you get these drugs to my people so that they are not in anxiety? They are less concerned whether there are tax barriers, they are less concerned whether there's corruption at KEMSA, they are less concerned if the drugs are lifted to their doorstep. They are more concerned around how do we get the drugs there. And I think the difficulty we've had between the US government and the Kenyan government in their conversations is, one, they have not involved people living with HIV in the conversations. People living with HIV only get information either from the media or from third parties, and that has been unfair. And so it is important that we ensure that they are involved and they are part of decisions that affect their lives. And so we need to have an honest conversation. And if KEMSA is being reformed and the stakeholders who are people living with HIV that consume the medicines that are brought in, why can't they be on the table to be able to voice their concerns around what reforms look like? Because the network of people living with HIV know where they are and know how to get medicines to them, and they can be useful in this conversation. So Gladys, I think it's time we need to put this conversation to an end, and that can only happen if we put people living with HIV in the room to be part of that conversation.
Okay, let's bring Patricia into this conversation. What is your stance?
Thank you so much, Gladys. I would just like to remind the leadership of this country that 2 million people, 1.2 million people take ARVs every day. So that means we consume 1.2 million tablets a day. So that is a clientele that you would want to have a conversation with, especially around issues of antiretroviral medication. As Dr. Ngugi has said, we also take Septrin. So that brings to 2.2 million tabs that are taken per day by people living with HIV. And we all know that we take this medication every single day because they are not a cure, but they're just a way that can prolong our lives. So when we are talking about ARVs for us, we are not protecting a job. We are not protecting anybody. We are only asking for our life, which we believe is protected, and we believe it is protected under the Constitution. So we want to be at the table, as Alan has said, so that when the discussions are being done, we are there to get to understand and also to make contributions so that some of these issues can come out very clearly. And one thing I would like to put to the government is that if they feel that the US violated our regulation, we have other options. Maybe the partners should not give us commodities. They can work with us on areas of structural and behavioral. But when it comes to commodity security, then let the Kenya government be the ones who will be procuring directly or start thinking about local production. Back to you, Gladys.
Okay, very well said. And I'd like to take a short break, but before I do so, let me come back to you, Dr. Ngugi. I mean, we need to move away also from the problem and create solutions. But before we get to the solutions, there is the question, fine, there are tablets that are stuck at the port. Are we going to see these drugs released, and how are you going to cater for the people living with HIV and bridge the gap?
Thank you. I'm smiling because Patricia has answered the solutions that already the government has been put in place. And I did want to say thank you to our leadership in the ministry because of what is happening now, we have already engaged local manufacturers that are going to be producing antiretrovirals for us in the near future. In fact, one is almost producing 800,000 tablets within the next 6 weeks. So we have already engaged one. And then secondly is the government has allocated money to ensure in the coming future that we will be able to transition commodities procurement to the government, so as it can then leave the partners to undertake the programmatic part, but at least commodities we procure, especially the ones that are very, very important of pediatrics and adults. In terms of the question you have asked of the stack at the port, already taxes were cleared, all of them. In fact, as we talk over the weekend, the US government released the laboratory commodities, and we gave instructions of the distribution that is already happening of the laboratory commodities. So what right now that has already been paid for, no, in fact cleared or waived, is the TLD, the antiretroviral, that specific drug that our clients take, more than 1 million clients take it. Already the government paid the taxes for it. So we are waiting for the US government to release the drug to KEMSA so as we can distribute it.
Okay. Yes. Now, the bigger issue here has been the US government saying they will not do business with KEMSA. Has this been resolved?
As our cabinet secretary stated, yes, I think it has already been resolved. But we'll be having a meeting this week at the Ministry of Health. And maybe after that meeting, then the ministry can be able to give the position of that. But we, as I understand, is that it is already being resolved on how we are going to work in terms of the commodities that they had committed to the government, that is per last year, in terms of the distribution and of those drugs. And even in the near future, how we are going to be able to ensure that we engage. Because we know that in the milestones that we have made over the years, it has not only been Kenyan government, but through the able and partners. And we have had cordial relationship with the US government over the years, and even with the Global Fund. And we are really looking forward as government to ensure that we solve this issue out. And as well, I think I want to answer Mr. Alan that we've been engaging the civil society and people living with HIV. For the last 1 month, we have engaged them 3 times virtually, and they explained to them the situation. They asked us the questions and where we are. Right now, as we talk, we have more than 1 million packs of 90s. That is around, 90s means like it's a bottle with 90 tablets. That is going to be received in KEMSA within the next 3-4 weeks. That was procurement by Global Fund and the government of Kenya. So we are assured all the way until August we'll have drugs for the clients. They may not be able to receive the 3 months that they were receiving before, but they'll be able at least to receive 1 month. But the ones which we distributed, the ones we saw they were being flagged off, we distributed more than 490,000 packs of 90s. Remember, we have only 1 million clients who are on antiretrovirals.
1.2.
Yes, 1.2. No, 1 million who are on that specific drug. So 500 will receive 3 months. So with the next month of May, June, July, they are sorted. But the others will be able to receive at least 1 month of drugs, okay? So, but as I've said, that if there wasn't that disruption that we had in the October, November, we will still be the same way that we were even during COVID when it hit. We were able to give 3 months of month dispensing to our clients. But we hope that these are a learning lesson as well to the government, that we should be able, I know, to secure this commodity. And I am grateful that through the National Treasury that we'll be able to put in funds to ensure that we can be able to not only locally manufacture it, but as well the government take lead in ensuring that it's the one that's buying those products. Thank you.
Okay, Nelson. So first of all, do you take to heart the reassurances being made by Dr. Ngugi, and also is this something that you think will bridge the gap going into the future?
Thank you very much for having me again. I wanted to demonstrate something here, but before I go into that, I have 2 points I want to clarify. One, that we are talking about HIV treatment, ARVs, but the stockouts or low stocks have been also in testing kits, reagents, and lab commodities. So during this period, it has been very difficult even to test, even for pregnant women who want to know their status. It has been very difficult for people on treatment to go and know their viral load. But I'm happy that Dr. Kate says that laboratory commodities, of which I'm also sure, I'm also aware, they were released to the government. And from this week now, people can now go and do their viral load. The second point is that for all Kenyans who are in treatment, majority of them and members of NEFAC, they know that the government of Kenya is providing HIV testing and HIV treatment free of charge. And they don't know about USAID, they don't know about the Global Fund. Maybe a few of us who interact with the NASCOP know about Global Fund. So for us, bringing the USAID and Global Fund in the discussion is very difficult, but we appreciate that the government goes out because this is a large population. You need 8 billion annually to treat these people. So if they go out and then talk to PEFA, USAID, that remains at their level. If I'm informed, during the struggle in December when they were following up, if I was aware, my role in January would have been to do a WhatsApp to our members and say, we are likely to experience low stocks. Please prepare for this so that you even receive for 1 month. I think
is this the point where you say you don't feel you have been involved enough in these discussions?
Yes, and I think Alan stressed it, because if we were aware, you know, when you say people living with HIV and they are at NEFAC, these are Kenyans. They would also want to help their government to overcome a challenge, if there's a challenge. When COVID came, we were explained that now you are going to get these packs. We explained to people. And in Western Nyanza, people even formed groups so that out of 20, 1 person can go to a facility and bring medication. And that was our helping Ministry of Health to make sure that people don't miss.
Okay.
And that is a point I'm emphasizing, so that we are informed that we are going to experience this challenge. Then we prepare, level of preparedness, then people don't raise alarm. But why I brought this here, this is the 90 pack that Dr. Catherine has talked about.
Okay, now Nelson, my director, says just hold on to that thought. We'll come back and you will take us through your demonstration in a moment. Now, quickly before I take a short break, Penina, do you feel involved? Have you been involved in any of the conversations around the ARVs?
Thank you. Not really involved, because everything is getting us by surprise, and it causes so much rumor mongering and so much panic. And I say again, we're simple people. We worry about daily living, how to make bread, how to get bread for the children, how to pay rent for the day. We shouldn't have to worry about drugs. These are things that we have always taken for granted. So the only thing that we are aware is some of the things that we read in the papers, very little engagement that we get. And so what we know that there are drugs in the country, the drugs here are for Kenyans, the USAID has provided the drugs. We don't know about which company, which global fund, which USAID. We want to know, why are there drugs at the port? Why are they not in our clinics? Why are we like backsliding? Because it takes us like decades ago when it was just it was almost unimaginable that people would be on treatment in the level that they are. We lost so many relatives because the only drugs that were available at Nairobi Hospital at 100,000 every 3 months. So nobody imagined we would get here, and we are so grateful to our government, to the world organizations that have made this possible. But we see ourselves backsliding. We see ourselves worrying about, will I get my tablets next week? And that's all we know. So can we be reassured? Can these things they're saying happen like immediately?
Very. And we take a short break on your world. When we come back, we had put across that question of the day: what needs to be done to ensure that there is constant supply of this life-saving medication for those living with HIV? That hashtag is a new normal, and you can also reach us on call if you'd like to talk to us using that medium. But for now, we'll be right back.
Digitized more than 30 million single sheets of paper. Nairobi has about 250,000 transactable parcels. Those titles that are both in the Survey of Kenya, in the cadastre, the land administration, land registration, and all the other departments of the ministry.
So yes, the digitization of land registries, how much is it costing the taxpayer?
There are two titles, for example, covering the same parcel of land. The system will not allow you to upload them.
If you read the Public Finance Management Framework, one of the provisions is that counties will mobilize on-source revenue through land rates. And I can tell you county governments are really banking on this digitization.
Sisi kama Kogalo team, saa hii game yetu imeenda class. Tunataka players wetu wapewe koti, ama namna gani? Suit. Wapewe suti. Tuxedo. Ivo. Goalkeeper kwanza tunataka friji wekewe pale kando. Double door. Tunataka kishika ball anaenda kwa fridge anachukua.
Ball gani hawakujangi kufunga, wanakuwa wamesinda huko goalkeeper.
To get Kogalo, dial *811 *850#. Skiza na Nation.
These flags are representing the people that live in Philadelphia. Diaspora wengi.
To make it in America, you need to be focused, steady, you need to be consistent, you need to work.
My Swahili is still pretty hopeless. Jambo Bwana, Missouri Sana.
You can take an African out of Africa, but you can't take out the African in them.
The experience in Kenya has been a great one. It's been positive. The weather is great. It's like our home city in Nigeria, which is Jos.
I watch Daring Abroad. Congratulations for what you do.
Try Panadol Advance for relief from headaches, body aches, and fever. With Panadol's Optizorb formula, the tablet gently breaks down in the stomach, quickly absorbs, and starts providing pain relief in 15 minutes. For fast and effective pain relief that you can trust, try Panadol Advance.
Thank you for staying with Your World. My name is Gladys Gashanja. Today, we are shedding light on the welfare of those living with HIV. Still with me, Dr. Catherine Goge, Head, National AIDS and STIs Control Program, NASCOP at the Ministry of Health. Nelson Otoma, CEO, Network of People Living with HIV in Kenya. Alan Maleche, who is the Executive Director at Kelin. Benina Mwangi, Executive Director at the Bar Hostess Empowerment and Support Program, a representation of key populations. And of course, Patricia Seroching, who is living with HIV and also a vocal advocate of the same. Our question of the day to you is, what do you think needs to be done to ensure uninterrupted provision of life-saving drugs for those living with HIV and AIDS? Well, this is what you have to say. Starting off with Kubasu Andrew, who says we should set up our own manufacturing plant in Kenya and stop depending on foreign supply. Thank you, Andrew. Daniel Makanda says sufficient drugs at KEMSA. We hear you, Daniel. Another Daniel here says Ministry of Health should not take any chances. People are dying. We hear you, and definitely we take more of your feedback even as you talk to us and as we try to figure out how we can ensure there's uninterrupted provision of life-saving drugs for those living with this condition. Now, Nelson, you were trying to demonstrate to us something to do with the drugs. Go ahead.
Thank you very much. I came with this so that I demonstrate another challenge that has come with the low stocks. This is the 90 pack, pack of 90 that Catherine talked about, which means if you are given this in a facility, you are sure you have your treatment for three months because it is 90 days. And this is the 1 month, the 30 packs. Now, what is happening at the moment is because manufacturers are not bringing this. They are bringing this and even the 2 months one. So if you go to a facility when they are low stocks, what they do is that this has already been opened and this drug is put in this paper for you for 30 days or it is put for you for 2 weeks or 1 week depending on the availability of stocks. Now that goes contrary to what we have been teaching people on behalf of NASCOP and Ministry of Health, because we are told if you get given this, you check if there is a seal and then you check date of expiry, and then you carry your drug home. But right now in this paper, when it is here, you don't know what drug you are carrying home, you don't know when it is expiring. That is the challenge we have. But this one, because they were there before, we are telling our members now, if you go to a facility, please carry this with you because facilities don't have it, because it is no longer coming into our country. What was shipped and what was flagged by KEMSA is this one, but they cannot give you this whole because some people may miss. And then now that is what is bringing rumors that what I was given, I'm not sure whether it is dolutegravir, I'm not sure what date this is going to expire, I'm not sure whether already they are expired, and I don't know which drug they gave me. So that is the challenge that is coming with all this, and we hope that we will come to a conclusion. Lastly, about this, I know last week some facilities came up with a solution, which we also agree with and admire. They were getting 3 people so that they give you this, so that you go and divide this medication at home or wherever you want to divide it, but which is fine because now the burden of doing that is on you. The challenge with that is that it only works for people who are openly living with HIV if you put them into 3. There are people who go to facilities, they want to pick this, but they don't even want people to know that they are picking it. In fact, if you meet them, they'll tell you, I brought a child or I brought my brother. So if you pair up people and you say the buddy system works like this, we need to prepare our team and know who can step forward and then pick this medication. Then we will overcome this. And we take the assurance from Catherine. What we wanted to know is for how long. And secondly, I think the question that we've been talking about, their partner USAID released lab commodities to the Ministry of Health and to KEMSA. We know that dolutegravir is in this region of East Africa is a very lucrative commodity, and that's why they are protecting it and they want to follow it. I think the demand they've said is that they want to distribute together alongside with KEMSA. So the question that you have been asking over and over, why would we have medication lying at the port and somebody need that medication? What if they expire there? What if the person who brought them take them to another country? And lastly, the point really is we know this is a temporary measure, and as somebody has said, Catherine has said, government of Kenya is taking this up and they will either procure or manufacture, but we know that will take time. As you plan to manufacture, you plan to procure using the 8 billion annually, why can't you use what has come next door, which you can just talk to your partner and it is released? And when USAID says they want to distribute alongside KEMSA, it is similar demand that people in the HIV are asking, because they are saying, when you are releasing these drugs going to counties, we also want to oversight. Please bring us on. That is what Alan was talking about. We need the involvement, even at county level. If you tell us you are taking them to Kisumu, we send people to see that actually what has come, because we also don't want rumors that the drugs that have been pushed to the counties are drugs that are not supposed to go to that county, because that also brings panic, anxiety, and a lot of things, and you know the investigation that is going on now. And I know somebody has said in Twitter that sufficient drugs are available at KEMSA. Why would keep them at KEMSA and people need them in facilities? And I know they are trying to throw the war to the counties, that it is you who have not called these drugs, we have them. But we don't have them, because last year we were here praising that KEMSA and Ministry of Health because drugs were available. This year we are here lamenting simply because we do not have enough for those who need it, and therefore that's why we adopt these disparate measures of dividing up drugs and putting up here something we cannot verify. So thank you very much.
Thank you, Nelson, for putting that across. Quality assurance has come into question. Dr. Ngugi, how can you reassure those that are partaking of these drugs that what they are being given in sachets are good for them, and also answer the other question that came up even during the flagging off, that some of those drugs are some that have been phased out in the market because of the side effects?
Thank you. All the commodities that we have, they go through several checks before they are released by Pharmacy and Poisons Board, but as well as within KEMSA. And then even when they are being received at the counties, we have able health workers who are oversee. By the time they are distributing the drugs to the patients, they are able to explain to the clients in terms of storage. And we know the inconvenience that this one has caused, the situation that we are in has caused the clients. But our able and well-educated healthcare workers in the facilities are able to explain to the clients as they pick their drugs, to ensure that in terms of storage. But I have said that the situation will normalize soon, and we're hoping as soon as possible, and hoping that within the meeting that we'll have this week, that we'll be able to sort out the issue. In the communication, the latest communication, the first communication that we received from US government on 26th of January, they informed us they only had 248,000 packs of 90s of TLD. That's what they have in the country. In comparison to the commitment of around 1.7 million packs. So even as a government, we know what is at the port is 248,000 packs of TLD. That's what we know, and that's what we already, that was already cleared by the government for distribution. And at the same time, I think I want to state in with that, as I'm here not really to spread lies, honestly, it's to reassure, and I know that there's a lot of anxiety with the clients. We are really working day and night to ensure that this situation is resolved, and as well that, as you have posed a question for the day, that our clients are reassured of drugs that next year, the other year to come, we don't want to get in the situation that we are in currently. And that to ensure that as well, even the pediatrics and even the many efforts and the achievements that made the years, we don't want to negate them. And so we are putting all measures to ensure that this occurrence is once and for all.
All right. And in as far as the investigation to ensure that what was released
Yes.
to the counties is not to harm them?
First of all, I think I want to clear that part. There are no toxic drugs in the country at all. And none that was released was toxic. Let me explain to you. We have several regimens that, like they have first line, second line, third line. Drugs that are taken by people living with HIV. Kenya is in Africa, the first progressive countries that when a new product comes in, based on evidence, then we are able to put in our clients on it. The specific drug that was being mentioned in the media, zidovudine, ranitidine, and nevirapine, is still classified under World Health Organization and is still being used by other countries. It's just us, we were able to transition our clients to a more optimized regimen, that is TLD, a bit more efficacious, another one that's a bit more tolerable to the clients, and achieving of virus load suppression a bit faster. In fact, the drug that you're using, DTG, is one which is being used in high-income countries. The other countries are still using that drug. And in fact, the stocks that we have, they are expiring in May and September of 2023. And in fact, we're looking of issuing it out or giving as a donation to other countries that are still using the drug. So it is still not toxic. And another, I think, confusion, and I want to clear it, is nevirapine. You see, there's nevirapine tablets and there's nevirapine syrup.
Yes.
Tablets is what was being mentioned and have clarified. It is not toxic. But we put our clients on fast regimen and good regimen, and that's the TLD now. Now, nevirapine syrup is still within our guidelines. It's still being used all over the world to prevent mother-to-child transmission of HIV. It is used as an infant prophylaxis for HIV-exposed infants in the country. It's still safe and the only product that we have.
So none of the medication that was released to the counties is toxic or is phased out in as far as its use?
No. That drug now, the one that went only to one facility,
yes,
it is phased out because there is no client. We have put all our clients on the best regimen in the world. So even what went, there is no client in that facility is using that drug. Yes, in Siaya County. Yes, no client is on it, and it's not that it is toxic, I have said. It's just that we phased it out. So no client is using that drug. But still there are other countries within sub-Saharan Africa that are still using the drug. And under WHO, it's still classified. Yes.
Okay, Alan Maleche, there is a conspiracy, or you could say the crisis is the fact that we have ARVs sitting at the port, and the USAID and of course the US Secretary of State said they will not do business with KEMSA until radical changes are made or reforms are made within this parastatal. When you look at this arrangement, in as far as KEMSA being the sole procurement arm of government when it comes to drugs and medical supplies, what is the conundrum here?
I think Gladys, the conundrum here is that government has a preferred procurer and supplier of medicines, which is KEMSA. And we don't have a problem with that. And if that's the case, the position is then make KEMSA work so that KEMSA works and there are no breakages in KEMSA, there are no leakages in KEMSA that ensures that donors have trust in it. And donors have before had a lot of trust in KEMSA. I've sat on the Global Fund Board. I have seen audit reports where KEMSA has been a model to other African countries. But what we are failing to address is what has gone wrong at KEMSA. And I know Dr. Ngugi may not be in a position to speak to that, but I think what needs to be done, Gladys, is to ensure, for instance, the issue of the argument whether there were face drugs that were sent out. What KEMSA would have done the day they were sending out the drugs, why not put on your website and say, these are the drugs you're sending out, to these facilities on these expiry dates and have that proactively out there, then that will kill the rumors. But if you sit back and paint the picture, you have sent drugs and everything is okay, you leave space for rumors, and then a question arises, if certain patients were first off drugs, how did they get to the facility? Who ordered for them? So where is the gap and what are the drugs still doing at KEMSA? And I think those are gaps that need to be addressed. But moving fast forward in terms of what needs to be done, Gladys, because I know we are running out of time. I think the key message by people living with HIV, and from what I've heard about them, it's they want a seat on the table. We cannot take for granted the fights globally people living with HIV have done to ensure generic ARVs are available. And something that we're also facing with COVID, with vaccines now, is because of the fight. And having them on the table to make decisions and not only updating them on Zoom calls is pretty much critical. We definitely want to ensure that if there are reforms going on at KEMSA, we must ensure that people living with HIV are involved. And thirdly, I think we must appreciate the danger of corruption. Corruption is not just the loss of the money. When donors lose trust in a system, this is what we're seeing. That the USAID, yes, has the drugs, they have the pot, they really want it to get to the people, but they don't want to take the risk. And I think what Kenyans should understand is that when you're dealing with a global fund or USAID, for any money that is lost, it's actually paid back to them in full, every single cent through taxpayers' money. They never lose. They're never the losers. It's Kenyans that are losers. And that's why we see the anxiety of saying, what can be done to make KEMSA work? And I think my final point on this, we need communication from the highest office to reassure us in writing that A, this is how much we have as ARVs. B, this is what we are doing to solve the impasses. C, this is the long-term plan to ensure that we have sustainable financing and local manufacturing of ARVs. I think a communication either from the Ministry of Health, from the President would be extremely critical to the communities of persons living with HIV to help find a solution to this particular impasse. Over to you, Gladys.
Thank you, Alan, for putting that across. And remember that question of the day, what needs to be done to ensure uninterrupted provision of life-saving drugs for those living with HIV and AIDS? That hashtag is new normal. We have Waiteka Batha who says, allow donors to distribute drugs to the patients without involving the government. We have another one saying, collaborative efforts from a serious ministry would easily facilitate local production of the drugs, acquisition of patents, creation of new drugs, research into new techniques for treatment, invention of new equipment, etc. It all starts with eliminating greed for quick cash. Remember that hashtag is a new normal for your opportunity to let us know what needs to be done to ensure uninterrupted provision of life-saving drugs for those living with HIV. We'll be right back.
Truth. Oh, we'll see about that. Before they send this guy to the big house. I say we get some justice for our people. What do you say, homeboy?
Yeah, man. I need help!
Oh! Hey! Why don't you stop them?
Because that guy deserves it. After all, the sheriff is dead. Because of him. You came back.
How have you been?
I feel like I can't take this anymore.
David, you are in the very same situation as when I came back from Mexico.
This is much worse. Along came love.
I'm saying ni aje? Nataka jo kujiuliza mjamaa jo alidiscover jo sambu inafaa ikuwe na kona 3. Samosa.
Imedu nini?
Inakuwaga na kona 3 sana, shindwa kwani hata discover ya kona 4 lini.
Msiwezi mekuraru.
Acha hiyo triangle atafuta hata kama ni pentagon.
To get samosa, dial *811 *928#. Skiza na Nation.
Introducing Kwetu Mix.
Okay, but don't need no intro.
Tangu tuingie kwa mchezo sindo heartbeat. Nairobi City tunairan kama athlete.
If you know, you know.
We have a banger.
Nisho, ni wapi uliniona?
Kwetu Mix on MTV.
Tutakuletea updates zote about all the trendy and popular entertainment events.
Yes, bang. Any vibe ya kibazu na form iko true.
Bazu, big man, bazu. Bazu. Mi ufanya biz na mabazu. Join me, Ted Agua, right here on your favorite channel.
Hatuna maneno kukwetu, tunapendana kikwetu.
Kwetu Mix on MTV.
It is the largest women-owned dairy cooperative society in Kenya.
Tulianzisha Masai Women Dairy Cooperative 2011.
Na tuko na real members 3,400.
We are collecting almost 45,000 liters per day.
Cooperative Bank has partnered with Masai Kajiado Women Cooperative Society to give them a line of credit of 44 million to be able to pay their members on time.
Wamama wamesomesha watoto, wamejenga manyumba.
Masai Kajiado Women Cooperative Society this Tuesday at 6:45 p.m. on NTV.
Try Panadol Advance for relief from headaches, body aches, and fever. With Panadol's Optizorb formula, the tablet gently breaks down in the stomach, quickly absorbs, and starts providing pain relief in 15 minutes. For fast and effective pain relief that you can trust, try Panadol Advance.
Thank you for staying with Your World. My name is Gladys Gashanja as we take stock of the welfare of those living with HIV and AIDS. My panelists are still with me, and I'll go over to Patricia. Definitely apart from the looming shortage, as we have discussed, of ARVs in the country, there have been other circumstances that have challenged the welfare of those living with HIV in the face of a pandemic. What is your experience?
Thank you so much, Gladys. One of my experiences is the loss of jobs. So that means loss of income, especially for women who at times are forced to do manual jobs in the informal sector. Like, for example, when we had lockdowns in Nairobi, and then smaller lockdowns, like a place like Isli, where you find that most women from Eastlands go to wash clothes, clean places, and get their daily bread. Then Isli was locked up. women were not able to access easily. But even the fear of COVID, people refused to have house girls or house managers in their homes because of the information people had created a lot of fear. So people lost their daily income. And that meant that women and men were not able to put bread on the table. And so some people opted not to take ARVs because antiretrovirals on an empty stomach is really bad. Some of us also have to take anti-TBs. Those are TPT for prevention. So that means we're taking 4 pills on an empty stomach. So that also is going to maybe be felt 2 or 3 years from now, the impact of what was happening and is still happening now. The other component was insecurity, where people are living. And my greatest fear, or one thing that has really terrorized me, is the teenage pregnancies. The teenage pregnancies has really escalated. We've seen incests, we've seen defilement. And when you see teenage pregnancy, that tells you that sex is happening without protection. And we are going to be looking at increased rates of HIV infection. It is also telling us that although we have laws in place, those laws are not being used well to be able to protect the adolescent girls, and also adolescent girls and young women. So we can all see these. We are seeing the media reporting them, but some of those cases are not being picked up by the media, but we are seeing them at the local level, in our villages, and in the estates where we live. The other component is non-communicable disease. For example, I live with a heart condition. So if you don't have an income, you are not able to see a cardiologist, then you are not able to pay for your drugs. So quite a number of us living with HIV are also living with non-communicable diseases, and we need to also pay for the medication that we take. So without an income, you are not able to do that. Back to you, Gladys.
Okay, Penina, you represent the key populations. How have you been able to bridge the gap when it comes to their needs?
It's actually been such a challenging time. Like when every announcement we listen to the news briefings and everything, and every time we hear there's cessation of movements, there's closure of bars. Right there, about 90% of our members lose their jobs there and then. But there are some members who live in these lodgings because they cannot afford rent and maybe be able to entertain their clients. So they actually live in those lodgings. They have nowhere to go. It's been very, very terrible. We also have like migrant sex workers, migrant sexual minorities, the gays who came from the other countries because there was war. It becomes really, really challenging that they get stuck in a country that has ceased movement, a country where it's impossible to even get food. So even as we're thinking of HIV and its effect, for some people say the HIV in my stomach, the hunger that I'm experiencing is going to kill me faster than anything out there. And it's been said that, yes, there is COVID. Yes, it is really, really devastating, but we are saying people are dying more from the panic, more from the poverty associated with COVID than from the COVID itself. There's been loss of jobs, the bars have been closed, rent is a problem, so people are outside. But even some are saying, let me stay outside, but give me food. I don't mind, chase me, leave me out of my house, but give me food for my children. And when it comes to the ARV shortages for the children living with ARV, we are seeing women cutting their ARV into half to be able to give to their children. It's really such a challenge. And when I had the good doctor saying something about the Kenyan budget had already been done, so there was nothing that could be done. That's why we're having the challenges of the shortage on ARVs. I was like, oh my God, but we do budgets in our organization. We do budgets in our house. So we know that if my child is sick and she was not in the budget of being sick, I will take food from the meat budget. I will take food from the maybe entertainment budget that I would have had and put it in the food. So I'm wondering, the government budget, ARVs, there's no way they could have sat and thought that they could have been rebudgeted and made sure that ARVs are possible. We don't need to know those details, but we're so worried about everything. And the least we want to worry is about accessing ARVs. Please do not take us back. Yeah.
All right, Penina, let me take you back to that question. What have you seen being done among this key population to bridge the gap on the community level?
Very little has been done. Very, very little. We've seen organizations once in a while, human rights organization distributing food, like they'll give 2 kilograms of unga and cereals, things like that, to 1,000 families. That is so little and so far between, because when is the next consignment? How do they live on that for a month? Very little has been done. We've been left to our own devices. And when we hear that more should have been done, that there's a way government should have cushioned us from all these disasters, we worry that we are never involved, especially key population, because we worry about being criminalized, we worry about being out of jobs, we worry about the poverty, we worry about the lack of enough engagement, especially for social protection. It is not there at all.
Nelson, what is your experience, especially with other, runaway issues that have come with the pandemic?
Thank you very much. I wanted to just touch briefly, very quickly on something we were talking about before, and then I get to your question. It is this issue of phased out ARVs. And there's a reason why ARVs are being phased out. It is based on scientific evidence that something better, well tolerated, with less side effects have come, and therefore what you are using, please put it aside, and you will then be able to continue with what is available. Now, ARVs or medicine is not addressed that if you phase it out, you put it somewhere, one day you can still take it, or even sure that one day you can go back to. Medicine, once it is phased out, like people now use dolutegravir. If you give them nevirapine or zidovudine as adults, and what we saw in the list being flagged was adult tablets, not pediatric, I think that was what was causing the worry. But in terms of coping, yes, there is a great challenge. And this great challenge is, like Patricia and Penina have explained. And you also know we are talking about people who are at low levels, because people who are at high level, if you live in Karen or Kitusuri, you have HIV, you can go to Nairobi hospital. Actually, even their women and children are not experiencing a stock out. This is a public health issue, public sector, and public sector because we are dealing with the poor who live in Kibera, Mathare, who want to go and wash clothes in Karen or in Muthaiga. And because of COVID, rightfully, you can't go in because people also want to keep a crowd away. And I think the greatest challenge, we say for people in the HIV are on treatment, the socioeconomic impact of COVID outweighs the health impact. And when those who get COVID recover. Now, the government was having social protection. I think the challenge we had was that the government definition of those who are vulnerable did not include living with HIV. And living with HIV also, because it is stigmatized, people may not come up to say that I'm living with HIV. You can't go to the chief. But we've reached out to the same Ministry of Health, we've reached out to UNAIDS, other partners, and they've been able to support where they can. Only that it may not be enough. And we continue to appeal for support outside the government structures of the chief of that rigidity. And we hope that it will be forthcoming, but we are also happy that the strict restrictions in these 5 counties or 4 counties were being lifted. As the world is opening and economies are opening, people who have HIV and are on treatment and who are strong can do their work and then have gainful employment and afford food and so on and so forth. But once we have very tight restrictions, that's why we will still go back to UNAIDS, to PEPFAR, to Ministry of Health. Please help these adolescents with this, help these older people with this, help these women who are breastfeeding with flour or with rice or with anything that they can take. So I think that is where we are, and we continue to monitor the situation.
All right. Now, Alan Maleche, I mean, the world is facing the pandemic collectively, and HIV is experienced in different parts of the world and much more in sub-Saharan Africa. What are some of the best practices perhaps we need to borrow from other countries in this country?
Thank you, Gladys. Indeed, some of the best practices revolve around how well have we as countries invested in our socioeconomic rights, the right to health, the right to food, the right to water, the right to education, the right to housing. And I think that is the underbelly that COVID has exposed in a number of countries in sub-Saharan Africa. And there is no country that's perfectly dealing with this. But the lesson we're learning here is, what are the measures that governments are taking in order to ensure that their citizens' socioeconomic rights are then taken into account? We have to ensure that social protection is not only a right on paper, but it's an active program that's extremely transparent. I think UNAIDS put hands together to support people living with HIV, but as I've seen with many donations, it is not sufficient enough to be able to reach everyone. It is not sustainable enough. And I think the key message we are learning globally from different countries, be it Africa, be it Europe, be it Latin America, is that at the end of the day, the onus lies with the government of the day, and the government of the day should be thinking through broadly around, how do I deal with the human being? How do I deal with the citizen in my country from a holistic perspective, depending on their different economic, social status, health status, and other factors to be taken into account. Over to you, Gladys.
Okay, and it's interesting that the theme for World AIDS Day last year, 2020, was actually Komesha HIV na COVID-19 hashtag tuwajibike as a government, and take into consideration the effects of the pandemic. When it comes to social protection, is that still in effect to ensure that we also support the adherence to drugs, as you've heard from Patricia and Penina?
You know, we have different sectors within the country to ensure that the other areas are taken into consideration. And this is the time, I think, you know, from the grassroots of the counties, that the clients were being supported, and as well within the different partners on the ground, to ensure that clients can be able not only access the medication, access the facilities for their follow-ups and reviews, but as well to ensure that in case of anything within their household, that they may be able to communicate. Yes, and as Adan has said and other colleagues, is that despite the efforts put, that we have seen quite a number of clients who have been affected by the pandemic in terms of food. We personally, many who have reached out to us, and you know, as well, even if you have 2, 3, 4, you have other clients outside there whom you cannot be able to bridge the gap. But I know the other ministries within the government have been able to, have tried as much as possible to reach out to that, the county government as well. But we know that because we never expected, you know, even the COVID-19 to last this long, it is still, I think, work in progress to ensure that our clients are able, not only the HIV clients, but other clients who are affected in one way or another, either in communicable diseases or non-communicable diseases, to ensure that they are able to continue with their life, but as well they are able to access their medication and take it. But we know it has not been easy. And this is a time we work together, you know, collaborating together, national and the county, and the different partners that we have on the ground to ensure that we can be able to shield our clients. But even the ones who are not sick, we have seen it, Gladys, that we have really been quite affected. But I know it double hits for the ones who are not feeling well and they need to have the medication before they take in to that the drugs that they have.
Mm-hmm.
Yes.
Now, as we bring this conversation to a close, I'd like to hear from each of the panelists in as far as the strides we've made as a country to actually end this epidemic of HIV and AIDS in this country has actually been recognized the world over. But as we have mentioned here over and over again, is that there are circumstances that are threatening these strides. I'll start off with you, Patricia. What do you think needs to be put in place to ensure that we do not eat at the gains we've made for years?
I think from what I've seen, I think that our two institutions within the Ministry of Health, that is NASCOP and NAC, need to take a lead in the HIV programming. Because what we've seen is that there are sometimes strategies that are put in place that are donor-led, and NASCOP is lagging behind. They only have to come in running, chasing what has already gone off. Like now the crisis we are seeing with medicine. I think Kenya needs to be proactive, not reactive. Right now, the Minister of Health is reacting. But if we were proactive enough, put things in place, because when you talk about policy, we have so much in terms of policy. What is lacking is the implementation. When you look at the Constitution, it's very clear about the right of health, the right to life, and the right to dignity. What then needs to be done so that these rights that are assured in the Constitution are met to the people of Kenya, people living with HIV being part of that. So I think the implementation of what we have need to be taken into consideration. But my last appeal to the Ministry of Health right now is for the students who will be going back to school, the ones especially in boarding schools. How will they survive with the 1 month distribution of ARVs? I think we need to do something very drastic to make sure that multi-month scripting is done to the students, the adolescents and the young people who are going to school, boarding, primary, and also the colleges, if we are thinking about to bring in the viral suppression down. So that goes to you, Dr. Catherine.
Okay, Penina. Penina, are you still with us? Unmute your mic, please.
Sorry. I'd like to stress again about the engagement, about inclusive engagement, so that I would be here also talking for government, talking with government, talking for government. It's not proper that we come and talk at crossroads in such a forum. And in this engagement, again, I go to social protection. The social protection that we need is a more engaging one. Like now what we have, the practice is for people to register at the chief's place. How will a gay man, how will a sex worker go to the chief and register and say, I have lost my jobs, the bar was closed, I can no longer get an income, and expect to be given some form of relief? It's not possible. So can the government use the right people, the representatives of these people who have connections with them, to be able to work with them in as far as social protection is concerned, if this social protection is for all Kenyans?
All right. Remember, our question of the day to you again is what needs to be done to ensure uninterrupted provision of life-saving drugs for those living with HIV and AIDS? We are still hearing from you. That hashtag is new normal. Eric Okioma, who says you must move away from treatment room syndrome. People embrace and implement meaningful involvement of people living with HIV. We must be at the table. Thank you, Eric. Another here from Daniel, who says the government should start our local manufacturing of ARVs. That's the game changer. That has been said here over and over again. Thank you, Daniel. John Imbali, who says Hukumolo people are really dying just because of non-availability of the ARVs. Who will come to their rescue? Naske, if you don't take the medication, then upate homa kidogo. That's the end of you. John Imbali, thank you for sharing with us. And I think even Dr. Ngugi, you have made note of that. Let's hear from Nelson. What do you think needs to be done so that we do not eat into the gains we've made over the years?
Thank you very much. For me, it's two things. With regard to the current crisis we are talking about, we are just telling the government people, especially the Ministry of Health, not to have the traditional aspect of Sirikali, where it is Siri. Struggle with people living with HIV. I think these networks and this civil society exist to help you do your work better. And if you reach out, we can be talking. And even for people living with HIV, even at county level, even at the village level, if you involve them in those structures we are talking about, if they know what is happening even at KEMSA, you will not have more problems. And I think solution will be found together. Lastly, and more importantly, I think partners can come in. USAID can come in, Global Fund. Let them do prevention, distribution of condoms, medical male circumcision, or these others. But when it comes to the premier, which is ARVs to people living with HIV, because this is treatment as prevention, I think we are calling upon the government to invest, to be procuring and distributing so that we don't have a stalemate like what we have right now. Because people really know the government. They don't know who other partner is doing this. And this is an area that I also want to support local production that will save us. But it takes long term in terms of investment. And in that long term, we hope we are going to work together. In the short term, for people who are getting medication for 1 week, people who are going to school and they need medication, I think the government need to urgently and drastically do something. And I don't think it is too late to go back to USAID and say, we want these drugs to be released, and we can work together to make sure that they reach people who need them. Thank you.
Thank you, Nelson. And again, I see a lot of you still speaking to the matter, what needs to be done to ensure we have an interrupted supply of life-saving drugs to those living with HIV. Tony here says, yes, we can. It's time we developed our own. This dependency syndrome on the West should be curbed. We have what it takes. This is the way to go. I have another one here from Eric, who says, please include structural interventions in the fight on HIV, not just politics of the day. Well, thank you, Eric, for speaking on the same. And remember that hashtag is new normal. Now, Alan Maleche, what needs to be done to safeguard these strides?
Fairly robust conversation, and I think 3 things in my view need to be done. I want to emphasize what Penina, Patricia, and Nelson have said, that when there is an issue involving people living with HIV, and not only people living with HIV, a community that will be affected by the issue, it is important and apparent that they must be given a seat on the table to express their voice, to express their concern. And so my call is both to the Ministry of Health, to the US Embassy in Kenya, to USAID in Kenya. If you're going on with these talks, please ensure that a voice of people living with HIV is on the table at the bare minimum. The second issue revolves around proactive disclosure of information by all agencies, not only about the number of ARVs that are in facilities, not only about when we're expecting the next talks, but also around what actions are being taken at KEMSA. Why haven't we seen prosecutions? Why is the Office of the Director of Public Prosecution not clear about what steps are being taken? Why haven't we seen what reforms are being taken? Proactive disclosure will help Kenyans, and particularly those affected, to be in a position to appreciate and make a judgment based on the information that has been provided. And by proactive disclosure, we mean things on websites, things in letters, direct communications to stakeholders. That is something government agencies should try to adopt, because that will help ease tension. Lastly, and what has been said by everyone, we need to find a sustainable solution. And given that the right to health for Kenyans is guaranteed and for children is immediate, which means any child missing any form of medication amounts to a human rights violation, we have to figure out where are we going to get more money in the budget to prioritize for health issues, and how are we going to promote local manufacturing. We have seen companies or manufacturing plants for guns, for bullets. I'm sure we can do the same for life-saving medicines. Over to you, Gladys.
Thank you, Alan. And still more of your feedback. Meredith says commercial health workers, or rather commercial sex workers, are having a very hard time accessing the drugs. Desmonio Mboto says our children's lives are at risk as we cannot get this medication that is so necessary for them. And we have one Meme who says we need to increase our local manufacturing capacity for essential medicines and supplies, and exploit flexibilities in TRIPS agreement to ensure this is achieved. Also ensure sustainable financing in the health sector. Dr. Ngugi, a lot has been said on this forum, and I think it was important to have this discourse so that we also understand other solutions that perhaps are in place or should be adopted by the government to ensure that we protect the welfare of those living with HIV and AIDS. Your last words.
Thank you, Gladys, and thank you, colleagues from the civil society and the networks. And I'm glad that their sentiments are very clear. It's in line with what we are thinking. And there's a silver lining in all this. You know, we have to think outside the box. And one of the big solutions was having local manufacturing of the important commodities, and in fact all commodities. And the government already took up that one when we had the cotomoxazole, you know, impasse as well. And we have a local manufacturer that is producing cotomoxazole in the country. So that one gives us sustainable, you know, for a very long time. I hear Patricia saying that definitely because of the students are going back, I think, by next week. We take note of that, Patricia, to ensure that we can communicate to the health facilities over the country, that they prioritize the clients who are going to go to boarding schools, that they can be able to access their medication, and at least, because I know they're going to go for several months, that they ensure that they don't miss their medication. Paureen, I hear you out in regarding engaging more with the sex workers, with the key populations, with the MSMs, and we take note of that and we'll act on it to ensure we can engage more, and we have different forums, you know, we can engage them. And in regarding to Alan and Nelson, yes, local manufacturing is a way to go. It's a way, it's going to be the sustainable way for us, and government allocation, not only for long term, but as well as to ensure that we don't have such kind of a situation in the near future. But as I've said, in regarding to, even though yes, we go to local manufacturing, this development and donor partners, we have had, as I've said, cordial relationship over the years. So as we sit at the table, you know, to ensure that we have a solution that is not only permanent, but as well that we be able to allay fears into, you know, to the different donors and the development partners we have in the country, to ensure that they can trust in terms of the funds that they give, you know, the taxpayers from their countries, that they, you know, that there's value for money of that still we need to be able to sit at the table and ensure that that one is sorted. And we hear that that part of ensuring that people living with HIV are wanting to be at the table. Yes, they're in different forums, but we hear you out now that they really want us specifically in this matter. And we'll have consultative discussions within the ministry and be able to get back to them on the way forward. But we are really grateful for this discourse, honestly. Very grateful knowing that all of us are thinking in the same line, local manufacturing. That's a sustainable way, and government allocation of the funds.
Okay.
Thank you.
And in matters ARVs, your reassurance?
Reassuring them that we have stocks in the country. Unfortunately, they may not be able to have the 3 months, but at least they'll have 1 month and some 2 months of the drugs. But that is only for a short time. We'll resume the normal of the 3 months dispensing very soon. Yes.
All right. Yes. Dr. Catherine Ngugi, Head, National AIDS and STIs Control Program, NASCOP, at the Ministry of Health. Nelson Otuoma, CEO, Network of People Living with HIV in Kenya. NEFIC, Alan Maleche, Executive Director at Kelin. Penina Mwangi, Executive Director, Bar Hostess Empowerment and Support Program, representing the key populations. And of course, Patricia Sero-Ching, who is living with HIV and a very vocal HIV advocate. Thank you all for being part of this very critical conversation, and even for watching this episode of Your World and giving your contribution in as far as what needs to be done to ensure there is an uninterrupted supply of life-saving drugs for those living with HIV. Well, tomorrow we'll be back here, same time, same place, as we focus on black tax, also known as family responsibility. Well, it is encouraged that we support family members that are less fortunate, but in the same breath, it is prudent that we understand how to create healthy financial boundaries that define needy and entitled relatives. More on black tax tomorrow from 7 a.m.